So thank you very much, the three speakers so far. So let's now go to some real-time action. And for this, we go to the University Hospital of Heidelberg, where Professor Raake and his team will show us a PASCAL Ace implant for the treatment of TR.
Hello, welcome to Heidelberg. Welcome to the University Hospital Heidelberg, to the hybrid OR in our cath lab. We have present a live case today for you. It's a PASCAL Ace implant for a patient with tricuspid regurgitation. First, I would like to introduce our team. My name is Philipp Raake. My second operator today is a senior physician from our department, Matthias Konstantin. We have technical support from Doreen Wood-Silka. Philipp Schlegel is our interventional echocardiographist, and we have anesthesiology with Ingrid Bangert and Anja Schüppmann. So our patient is here in supine position on the in our hybrid OR. We have the fluoroscopy here. We have the patient is intubated and ventilated, so we usually do this for these kind of procedures as we place an transesophageal echocardiography probe, and the patient needs to be in a stable position over time. The echocardiography is placed on the other side, and we already have started the case. So we started with a puncture in the femoral vein. We placed a ProGlide suture before to close the femoral vein at the end of the procedure. The guide for the PASCAL system has a 20 French outer diameter, so we have good experience with clothing the groin with the ProGlide system. Now we have placed an implant super stiff wire in the cava superior vein, and we have placed a dilator so far. So first we would like to introduce the case. So Matthias Konstantin will quickly give you some infos on our patient for the day.
Hello, also from my side. Today's case, next slide please, is a 80-year-old male patient. He has a coronary tree vessel disease and is in a status of aortic valve replacement with a bioprothesis in 2011. He has a severely impaired cardiac systolic function with an ejection fraction of only 30%. He has also a severe diastolic dysfunction due to a transthyretin wild-type amyloidosis. His clinical presentation is primarily a right-sided heart failure with still peripheral edema. He has functional NUA class 2 to 3. And the cardiac biomarkers are clearly elevated, with cardiac troponin is 55 and the NT-proBNP is 3,500. The Euroscore 2 is 8.8%. And the procedure today we do because we find a severe to massive functional tricuspid regurgitation, and the systolic pulmonary arterial pressure was 60 millimeters mercury. On the next slide, these are the picture we have taken when he came to us. Is first a transthoracic apical for chamber view. You clearly see this massive regurgitation of the tricuspid valve. And on the next slide, I we like to show you also a transgastric short axis view where you see a rather central jet of the tricuspid valve. I would like to give further to Philipp Schlegel to show you the current picture of the echocardiogram.
Thank you for the introduction. So, well, we have here a case, as Dr. Konstantin mentioned, which is, especially from echo side, rather challenging due to the cardiac amyloidosis. And as you can see here in our transgastric view, we have here the septal leaflet, anterior leaflet, and we have two scallops of the posterior leaflet. Currently under anesthesia, the TR appears less severe because we also optimized medical and fluid management beforehand, but what remains is still this TR here between the septal and anterior leaflet, which you can see here pretty well in the color Doppler. In addition to that, we have only a good visualization regarding the inflow-outflow view from a deep esophageal view. And as you can also see here pretty well, is we have enlarged scallops, and we have, in addition to that, in the let me show you this real quick. Really prominent eustachian valve, which you can see here pretty well, which is rather rigid and in a length of around 2 centimeters. So here should be the inferior cable vein, the anterior cable vein, and this is where we have to go along. And here again you see this pretty thick and shadowing septal atrial septum.
Okay, so we will go on with our case. So this is really a challenging case. As you see that the imaging in this amyloidosis patient is quite difficult with the thickening of the septum. So this is really a challenging case. So we will see how it goes. So first thing, I don't know if the panel wants to discuss a potential strategy.
Yes.
We will now go on with the case.
Why don't you proceed with the case, and we will discuss some of the features that we heard from the presentation. So the first thing that I would like to ask Stefan is this now functional or secondary TR, or would you call this primary, or is it mixed, in your opinion?
So this would be a secondary MR. There's a lot of discussion going on for both in the MVARC and the TVARC situation, how you align with the nominations of the different etiologies of both mitral and tricuspid regurgitation. I think as the guidelines moved to primary and secondary, we're a little bit fixed to these nominators, but you can explain the subtypes. And I think naming the subtypes becomes more and more important. So in the mitral, you should differentiate functional disease from ischemic functional disease, which is a totally different entity, which has a different outcome. And also here in the tricuspid, we have to see that there are multiple influential parts in having rigidity of the ventricle, like in this case, which is an amyloidosis. So we have a diastolic and systolic impairment, not necessarily a valve impairment. We have then the valve group that can cause TR. We have the still called primary situations of pacemakers, for instance, which is very important and is becoming more important than we previously thought 5 years ago, because we're looking more closely actually at the valve and the potential comorbidities and co-standards that cause actually these regurgitations. So I would call this a secondary tricuspid regurgitation, definitely, and this is caused by myocardial impairment of perhaps both the mitral, the left ventricular, and somehow the right ventricular myocardium with the amyloidosis as a prime cause. How would the rest of the faculty see this?
Yeah, Peter, what is your opinion? Because I had the impression that I saw quite some prolapsing and redundant tissue.
Yes, I completely agree with this. With these points from Ralph, we see also a lot of patients with amyloidosis at our heart center here because we have a great amyloidosis program, and the anatomy that we've seen in this case from Heidelberg is quite typical for this cohort, and it depends on the age of the patient, the kind of amyloidosis, and the mass of additive protein that is in the tissue. And I think this might be an explanation for the anatomy we've seen in this particular case from Heidelberg.
And then, Philippe, for you in Leipzig, would you consider this pulmonary artery pressure of 60 millimeters of mercury a concern? And would it also help guide your strategy to reduce your TR to a certain degree? Does it affect your strategy?
So we've seen from two analyses that when you have pulmonary pressures, the outcome of treating tricuspid regurg depends on two things. First, whether you have a concordant or discordant diagnosis of pulmonary hypertension, meaning that a concordant diagnosis is high PA pressures both on invasive assessment and on echo, which is normally a good sign and is associated with favorable outcome. Discordant diagnosis, and these are patients where echo severely underestimates PA pressures, that in those patients the result is not satisfying, and there we would have a harder discussion. And the second thing you have to look for is pre as opposed to post capillary pulmonary hypertension. Post is certainly much better in terms of outcome as compared to pre. But just the mere number and the systolic pressure per se is not enough to make these decisions. Maybe one thing I'd like to add is, especially when you have atrial tricuspid regurg, so relatively normal right ventricle, but severe right atrial enlargement, you can have functional TR with some pseudoprolapse. And there again, the discussion starts whether it's a mixed etiology, whether it's function or primary. But I think this is a typical example of a functional TR with pseudoprolapse.
Great discussion. So let's go back to Heidelberg. So Philippe, where are you? What are you doing?
Too much flexed.
So we've placed, so the PASCAL system is a three-part system. So the first thing we did, we placed the guiding catheter over the stiff wire in the right atrium. We removed the dilator and the stiff wire, and then we introduced this is the steerable part, and this is the implant catheter. And we are now at the point that we are steering down to the tricuspid valve, which is a little bit challenging as we have a very pronounced Eustachian valve here. So we're trying to get around there. And we are struggling a little bit at the moment, so we'll see if we get around there.
Don't see him there. There is the catheter. I think it's too much flex.
I would this is a very pronounced Eustachian valve. But wouldn't you think that because it's also a huge right atrium that you should be able to get around this, or can it be that difficult?
Yeah, we are trying, so we'll get there.
So Stefan, any tips?
I think we can use the sheath. So the sheath is currently, I'm not sure at what angulation are you currently working. We typically like to work at an REO 20 slightly cranial, which is the typical plane of the tricuspid valve. And what we can do there is that the basic sheath actually can help you to actually put the Eustachian valve down. So currently you're not using that. You're straight with the big sheath, which has the highest force actually to get down. So perhaps a slight anterior elevation and or to help with the curve could also help you to get better down. But we have to see the clip there, that it's on the right pathway. Do you see it?
Yeah, I'm turning.
So it should work actually. You can come from a more lateral position. So go off the septum and then you should come down. there is no Eustachian valve. So you're stuck a little bit before, I think, more in the direction of the coronary. You're not yet in the right atrial chamber on the lateral wall. So I typically like to take an inflow chamber view, which is, as you already do it, you see you're stretched a little bit and you go against, so to look at the aorta and then to flex down there. And actually this interior part and also a little bit more lateral part is quite beneficial. So this would be rather, yeah, now you're down and now you can flex and advance. Now you're through. Yeah, and you simply advance. Very now you're nice. In the chamber. Looks good, you see? Perfect.
Yeah, nicely done.
Perfect tip.
So this is the inflow chamber. Actually, that's the best to steer. You see the aorta on the right-hand side. So this is anterior, and the flex goes posterior to the 5 centimeter sign at about 9:30. Now you're perfectly aligned to the commissure already, and with this prominent Eustachian valve, typically treatments in the anterior to septal leaflet are easier than to go very posterior. Of course, you can do that, and you have to overflex, but anterior will be easier actually here. So you need some anterior movement with the to get off a little bit with the shoulder in the right image to get away from the septal hugger a little bit, and then you have an optimal position already. I think you're down to the valve. Looks very good.
Yeah. So I would like to correct this septal hugger a little bit. I usually do that when I turn the guiding catheter, the flex knob a little bit, and turn the guiding catheter a little bit counterclockwise and the implant catheter a little bit clockwise. And you can see I can turn the device in the right direction.
This looks very good, actually. That's the movement that is anterior, and this gives you some more height and some more distance from the septum, which is down. Very nice.
Yeah. Okay, so I think we want to open the device and see which one's the anterior. You know, the PASCAL device has a nice function of independent grasping, which we often use in tricuspid valve disease to do an independent grasping. And that's why we want to, at the beginning, we like to know which one is the right, which one is the anterior clasp. Usually the one on our side here is the anterior clasp, but we want to see that once before we enter the valve. So we open the device. The device is opened by turning the actuation knob. And then we can, this is the sliders which actually maneuver down the clasps. And when we try to get a good image in the echo, so I will rotate the clip a little bit to get in the right position. Könnt ihr dann die Arme einstellen im Echo für mich einmal? So when we push down the sliders, both simultaneously, both clasps go down. You can see that in the echo. You can see the movement here. And now we move this one here, which I suspect to be the anterior, and this is the anterior one here. So we know which one's the anterior one, which is important for our maneuvers later. So let's, I would suggest that we switch to transgastric view so we can do our final adjustments.
Yeah, the clasps were not fully elevated. Yeah, you did that.
Yeah.
For Philippe Lutz in Leipzig, is there an added value in for using ICE, intracardiac echo, in these TR cases?
I guess there is in some instances, but I personally haven't used it. I'm not sure whether it's a particular cost-effective solution. And I think with the right patient selection, you will get around with TEE only in almost all patients.
Stefan, what is your opinion on the use of ICE in tricuspid cases?
We have done a single-digit number of ICE cases, Actually, in patients with a mechanical aortic and mitral prosthesis, ICE is very helpful because otherwise you only have a deep esophageal and a transgastric view to visualize the tricuspid valve. So in these cases, actually ICE may be beneficial. The second point that may point to ICE in the next 6 months is that you can do tricuspid valve implantations or tricuspid repairs without any intubation or sedation, like TAVR. So I think tricuspid will become, over the next 2 years, a non-sedation procedure, perhaps.
Interesting. Okay, let's go back to Heidelberg.
So here you can see we are in the transgastric view, and we are trying to find the right spot where we want to start with our first grasping of the valve. So our strategy in this case, I don't know what the panel thinks, but our strategy was to place one clip between close to very central in the anterior septal commissure, almost there where we are already. So so you can see now a transgastric short axis view. The anterior leaflet is on the bottom, the septal leaflet and the posterior leaflet, and we are almost in between the anterior and the septal leaflet. So we can turn the device a little bit counterclockwise maybe to get a better position. Ist der dann offen? Kannst du einmal?
Von oben.
So we are in capture ready position. So that means the device is 180 degrees and we are moving to the right spot. So by turning the steerable in the counterclockwise direction, the device will turn anterior to the anterior leaflet. By turning in a clockwise manner, it will turn to the septum. And when I push the whole system in the patient, we will go more in the anterior commissure. By pulling back, we go to the posterior commissure. And a similar maneuver I can do with this flex knob here on the steerable. So if I unflex, I go more to the anterior commissure. If I flex, I go more to the posterior commissure. So this is the way of maneuvering the device to the right spot in the tricuspid valve. So I will maneuver it to the right position. I'm sorry, I didn't get that.
Philip, what benefit do you see in the transgastric view? It's interesting. It's something we didn't do actually a lot in the last 10 years, but in the last 3 years with the tricuspid repair, transgastric views have become more and more common. So what's your personal experience with the transgastric view compared to the transesophageal views that we have seen in the talk from Philip? So what's your impression on the transgastric view? What is helpful or not helpful?
I think it's super helpful. So most of the grasping we did in the transgastric view, because usually you get better images and you can, I think for the maneuvering, you get more. I think it's, for me personally, I can easily navigate to the right spot where I want to place the device. And usually what we do in this view is go deep into the below the valve in this view, transgastric, then pull the device back a little bit anterior, try to get the anterior leaflet, push down the anterior clasp, and then move towards the septal leaflet and push down the septal clasp. And by this Tarzan maneuver, try to overcome these gaps. Sometimes you manage to get both leaflets at the same times, but my experience is that most times you need to have this feature of independent grasping. And we like to do that actually in the transgastric view.
We discussed the two different sizes, the PASCAL P10 and the Ace, which is 6 millimeters instead of 10. So what do you personally see as being helpful? By Philip, there was a strong vote for the Ace system. What's your Heidelberg experience on that?
Yeah, so we exclusively use PASCAL Ace for tricuspid because the device has a little bit narrower profile, and when you maneuver in these chordae of the tricuspid, which are really more pronounced than in the mitral valve, it's a little bit easier to navigate the device within the chordae. And second thing which I really like about the PASCAL device is that you can elongate it completely. So recently we had a case where we got entangled in the posterior septal cords, and we really had struggles, but we managed to get out of this entanglement by really elongating the device, and which I think is a good safety feature for the device.
So Philip, you're addressing one of the questions from the audience, where you discussed the benefit of using PASCAL Ace. So especially when you approach the commissures, you would prefer the PASCAL Ace, right?
Correct. Yeah.
Yeah. And another question from the audience is: Do you anticipate using more than one PASCAL device?
So for the cases we did, I would say that around 40% of the cases we use one device, 60% we use two devices. In really rare cases we use more than. I think one or two cases we use three devices. And usually we start, like in this case, with an anterior septal grasping. And sometimes we place a second one, posterior septal, with the so-called clover technique. It's depending a little bit on the anatomy and where the most significant jet from the tricuspid regurgitation comes from. So we did our first grasping already, so you can see that the anterior leaflet is a little bit under tension, also the septal leaflet. I think really important for the tricuspid, so we have done around 900 mitral procedures, and the difference in tricuspid is that you nearly need to be sure that you have enough tissue within your device. And I think this is one of the key steps, that you really need to make sure that the leaflet is going all the way to the spacer of the device.
There's another question, a practical question from the audience. Do you need to be an experienced PASCAL user in the mitral space to embark in the tricuspid space?
So my personal opinion is, I think it's helpful to have some experience with mitral. I think the access to tricuspid is a little bit easier with the device, because you don't need to go transeptal. I think it really helps. For me, I think it helped to be an experienced PASCAL user on the mitral side for the tricuspid side. So I think some experience on the mitral side is really helpful when you start with tricuspid.
Yeah, clear.
So we need some feedback from Echo. What do you think?
So far, I think from what I can see, we had a comparatively good grasp. Anyway, I would recommend to have a look at this from the inflow-outflow view in the capture-ready position, and to see how much of the leaflets is on the clip and on the PASCAL, and then we will
so what we typically
have to take a look at this in depth.
So what we typically do is that we go back to capture-ready position. So we open the device to 180 degrees, but we leave the clasps down, and we want to see how much tissue we captured with the device. Ist das jetzt 180? Ja. Yeah. So sometimes on the mitral side, you can sometimes see the clasps when you have good leaflet insertion. You can see the clasps lifting a little bit. In tricuspid, you don't always see that. So we can try if we can see that in this case. If we get some lifting, try to get a position where we can see that with the X-ray. So we don't see that in this case. It's usually in tricuspid, you don't see the movement of the clasps. So now it's really a little bit the challenge in this case that with the amyloidosis, that we get good images here. I think there is some, I can see the septal leaflet, where is some tension on the septal leaflet. With the anterior, that's lifting a little bit down there. So that might be that we need to get a little bit more of the anterior leaflet.
I will try to optimize this a little more.
Movement of the posterior leaflet, whether you actually pulled so much on the anterior leaflet. What's the impression of the other panel members?
No, I agree. I think the septal leaflet is nicely in, but the anterior needs some more
Redo.
more tissue in. Don't think that's sufficient.
So what we can do is a leaflet optimization. So what we do is that we trying to get a little bit more anterior, and we open the anterior clasp and try to get a little bit more leaflet into the device. Sometimes you lose the leaflet, so you have to redo the maneuvers you did before. So when we get a good image in the mid-esophageal inflow-outflow here, we can try to do an optimization of the anterior leaflet. So there we get some good image. So we remember this one is the anterior. So I will move a little bit anterior. I will close the device slightly. Ja, das ist okay. Mach mal auf. We open the anterior.
Yeah, so this is separate grasping now and optimization. That's a nice demonstration.
You can see that this goes quite nicely. It's going in. So we close again.
Yeah.
Okay. So this is leaflet optimization, and you can do that independently on the anterior septal. It's my experience that it's harder when you have captured. I personally think it's not risky. So one feature I like about the PASCAL device is that the device at the tip is not. I don't have a fear of perforating something with the device because the tip is a little bit flexible, and so when you touch the wall, I would not be anxious to get a perforation. It's a little bit harder to do when you grasp the septal leaflet first and try to move over to the anterior or posterior leaflet. In my experience, that's harder than the other way around. So when you clasp the anterior leaflet first and then move over to the septal leaflet.
Yeah. So Peter, do you often use this leaflet optimization? Or is this something exotic, this maneuver?
No, I think it's exactly what the last point is quite important. As you have the septal leaflet is very difficult.
Sieht doch eigentlich so schlecht aus, oder?
Thereafter, the septal leaflet.
So we've closed.
Out. You don't hear me?
So we closed the device and we looked for the color.
Okay, you hear me again?
To get an idea.
Yes.
Yes.
Okay. So the last point is most important, that you have to grab first the leaflets of the free wall, so first the posterior, first the anterior leaflet, and then swing over to the septal leaflet, not the other way around. And it's very often like this. There's the large anterior or posterior leaflet needs to be refined by using the independent grasping. And it's important to mention that when you swing over with one leaflet fixed, then it's necessary to go in the medial position between the leaflets before you close the device, so that you don't have additional tension on both leaflets.
Okay. So Philip, what is the result so far by echo?
Yeah, I think so Philip, from the echo, what do you think?
So, well, it's not too easy to say, but, well, as you can see here, we got some part of the anterior leaflet on. However, it's just going here, as you can see, I try to show this, here into the device, and, well, one would like to have a little bit more of the leaflet in there, so maybe even have a little different clocking of the PASCAL device to achieve that.
Yeah. So our echocardiographer suggests that we turn the device a little bit counterclockwise. I think that's a good idea. We can do that. And to get more like a 1 to 7 position to 2 to 8 position.
And
so we'll try that.
Perhaps you don't want to be as aggressively central, because here you really go into the indentation between the anterior and posterior leaflet, and this gives you less leaflet material in the PASCAL device. So yeah, like this, I think this rotation is much better. And I would start, as mentioned by Peter already, I would start rather a little bit interior and get this flat in, very nicely controlled, and then move over to the septum. But this looks much better. I think the rotation improved a lot.
Ja, ich weiß ja.
So Philippe, would this be a different scenario if you would have opted for a PASCAL rather than a PASCAL Ace? So in Leipzig, Philippe, in Leipzig?
I think in this case we certainly would have chosen a PASCAL Ace because it's not, the TR is not massive. There is not a terrible lot of space to place your device. Imaging is okay, but slightly challenging. So there's no reason to use a device which is larger, potentially more difficult to steer, and maybe not as nicely to be seen on echo as the PASCAL Ace.
And how long would you focus on optimization maneuvers rather than considering another PASCAL device? So 2 PASCAL devices instead of 1.
Yeah, that's cool.
We would focus a lot on optimization maneuvers. We would focus a lot on making sure that the leaflets are as much in as possible, that the clocking is perfect, all these things, because you don't get it right with the first device. There is not that much to save with the second. You really have to get it right and done with the first device. And if that's perfect and you have residual TR, then you can think about a second device. But the option of a second device is not an excuse to be sloppy with the first.
I totally agree. I would go for, and 1 device could be enough in this case. So I think it's more the optimization of the position and to get between the cords. Actually, that's an under-recognized situation we saw in the actually mid to deep esophageal view, that we had a rolling of the anterior leaflet. And I think this is one of the issues why 2 wide devices are not ideal in the tricuspid space, because Philip has shown this nicely in his talk. There's a dense and unpredictable chordal cum in the tricuspid valve, and this is why we have to get with the devices in between and not stretch the cords. If we stretch the cords, then the leaflet will automatically come from a straight position into a rolling position. I have to move my hand a little bit in. So it's like this, and if you touch and the cord is here, and you touch the cord, then you will roll the leaflet. And this doesn't help you in getting away from the tricuspid regurgitation. So my strongest concern on treating tricuspids is always to get the leaflet flat in. And this can sometimes be done by simply because the shape of the ace is very much flat here. So it can be even a mild rotation to get in between the cords. Then try to address the cord with the that is longer, more durable, which is typically the anterior one first, and get to the septal and close it. That's the strategy, at least how we do it.
I think these were very important comments, and I think what the takeaway for me at least is that we have to use this technology to its full potential rather than just jumping to to a second PASCAL first. So definitely consider the technical solutions within one PASCAL device.
So in the meantime, we rotated the device in a 9 o'clock position and moved in the posterior commissure. And we grasped the posterior leaflet first and then the septal leaflet. And then we did an optimization of the posterior leaflet. And we think that we are in a good position. Got a good reduction of TR, as you can see here. And we think that the leaflet grasping is fine. Einverstanden?
Ja.
Gradient war auch okay, oder?
Haben wir noch nicht gemessen.
So, einverstanden? Ablösen?
Ja.
So, for releasing the device, we have to cut the sutures here on both sides. We open on the slider and we pull the cord, suture. We remove the safety pin and we turn the release knob counterclockwise and we hold the actuator knob 8 to 10 times.
That's okay. Kann man das mal so springen lassen.
And the device sits really nicely on the posterior septal. It doesn't move at all, so that's always a good sign. Achso, ja, kann man auch hier. Moment. So gut? Ah, das sieht super aus. Komm, fertig.
Ja.
So now we have a good result. The device is in a good position. We will check our final results, and if we are satisfied, we will remove the guiding catheter. So we remove the stabilizer first. Okay. So we will unflex everything. So we have a straight device. And we remove the guiding catheter. So at the end, we can compare the result from the echo before and after. Sie könnten Heparin antagonisieren, die Hälfte. Ja.
So this before and after. Ja, ist ja super.
So on the left side you can see the tricuspid regurgitation before, and the right side you can see there's almost only trace of tricuspid regurgitation left, so a very good result for the patient. And we'll see how his symptoms hopefully will improve with this good result. Okay, thank you very much from Heidelberg. We are happy with this case and hope to see you soon in the future. Thank you.
So thank you very much to you, Philipp, and the entire team in Heidelberg. It was impressive to see how PASCAL Ace is also delivering more options to patients with functional tricuspid regurgitation. Thank you, and I hope to see you very soon in real life.
Yeah. Okay, thank you very much. Bye-bye.
Thank you, bye.
So I would also like to thank Philipp Lurz, Ralf-Stefan van Baardeleven and Peter Lüdicke for their contribution and their excellent presentations. And now we're going to move on to a final wrap-up. So we've covered a lot in these last 90 minutes, focusing on Edwards Lifesciences and their technology to treat functional tricuspid and mitral regurgitation. I think PASCAL is a technology that is here to stay. We see already the new device iterations that make a difference. We've also seen a glimpse into the future with this impressive presentation of the EVOC system. I think there is a lot of potential, and I think the future looks bright for patients with functional MR or TR. I'd like to thank Edwards Lifesciences for the support of this webinar. I'd like to thank again the faculty, Peter Ludeke, Philip Ruurts, Ralf-Stefan van Baardeleven and Philip Raake. I thank you for supporting this webinar and and joining us for the last 90 minutes. This session can also be viewed on demand on www.radcliffecardiology.com. Thank you very much for being with us, and I hope to see you around in the near future. Stay well, goodbye, have a good evening.